All right, this is a recording. This is your video lecture for the week. Hello, cohort 10. Happy Monday, happy Sunday, whenever you're watching this. I'm going to do a brief lecture over cardiopulmonary conditions. I've got a nifty PowerPoint. I'm using the smartboard in the ADL lab. I thought this would be the best place to do this. But now that I see this PowerPoint, I'm not sure that's going to show up all that great. So I'll try to be more mindful of that as we go through the next, as we go through the course. Hopefully you can see that. You may have to blow it up a little bit, or maybe even better, follow along on your laptop off to the side. While you're watching this video, go through the PowerPoint, and there's a lot of really cool links in here for you to click on. And as we go through, I'll tell you more about those. But you can watch those videos. You can pause me, watch a video, play me again, pause me, watch a video, and do that while I'm going through this. Or you can just do it after, whatever you want. All right, so adult conditions. We're talking today about cardiopulmonary conditions, and you can see from this map, similar to the stroke map that we had, this data is a little bit old, but it's still effective, and it still tells a story. Different parts of the country, we see a higher incidence of death rates due to heart disease. So we're going to talk about various conditions related to the cardiovascular system and cardiopulmonary conditions, breathing, blood flow, heart function, etc. A lot of the patients that we see in OT have congestive heart failure, coronary artery disease, COPD, which we'll talk about all these, but so we see so many people in our practice that have respiratory, cardiovascular, cardiopulmonary conditions. So this is a big deal for us. And I almost didn't do this during a blended course, but I had to pick something, so we ended up doing during the blended week. But so you can see that based on this map, that there's a higher concentration of deaths in the South from heart disease. And we joked about this a little bit maybe during our stroke time. We're talking about strokes, or there are more strokes and more stroke deaths in the South than there are in other parts of the country. And it could very well be to climate, it could be to what we're eating, our lifestyle, all the different things that play into people's health. I joked about gravy and how, chicken fried steak and biscuits and gravy, gravy's a beverage in the South. I love gravy. So, I don't know, maybe it's the gravy. But anyway, there's something going on here. We see less of this in other parts of the country. There is more red up in New England and up in these northeastern states with heart disease and death rates than there was on the stroke map. So, that's interesting. But anyway, we gotta get healthier in the South, don't we? So coronary artery disease, we're going to be talking about stuff, and coronary artery disease puts people at risk for more other things. So for example, coronary artery disease, you have in the blood vessels, the arteries especially, you have this buildup of plaque inside the artery on the arterial wall, and as that plaque builds up, it begins to diminish the blood flow that's going through that artery at that spot. So obviously, when blood becomes restricted and it's not allowed to go through the artery, it puts people at risk for developing a stroke. We talked about that last week. An occlusion of blood supply is the main cause of stroke. Also could put people at risk for heart failure and heart attacks. So coronary artery disease is a big deal. The risk factors for coronary artery disease, as you can see, obesity, smoking, diabetes is a risk factor for coronary artery disease. Because when I think of diabetes, I think of we'll talk more about that later in another week, but I think of it's a circulation. It's related to blood sugar, of course, but it's also a circulatory issue. Okay, we'll talk more about it later. Family history, age. You'll notice that obesity and some of these are going to show up. All of these are going to show up in a variety of conditions, putting people more at risk for that condition. I was preaching not long ago, and I was talking to about how my students, when I teach conditions, my students pick up on the fact that being overweight puts people at risk, at increased risk for a lot of these conditions. And because they're smart, so they pick up on that. And so I was talking about the new year and health and all that, and we're talking about them taking control of their health. And I'm speaking as an occupational therapist there while I'm preaching, of course. But you, as an occupational therapist, have such an opportunity with each one of your patients to speak into their lives about, with authority and with expertise, about health, how they can be more healthy, or at least less unhealthy, depending on how you look at it. And you're going to be teaching these people. We don't see people with the primary condition of coronary artery disease per se, but we see them usually once they've had the stroke or the heart attack or they have congestive heart failure or something. And so a lot of times they haven't been educated. They're told to eat better or be more healthy. And then they go home and they're like, well, okay, how do I do that? And they know something about it. They know they need to eat healthy and they need to get more exercise. That's what all my patients tell me. I need to eat healthy and I need to get exercise. So I can really break it down more, be really targeted and really specific about what that means. To be more healthy, to eat what you put into your body, is how I say it, and what you do with your body, the activity. And exercise is one good, healthy activity. So anyway, you're going to notice that these recur and put people more at risk for all kinds of things, because this is just part of health. Being overweight is not good for your health. It's bad for your health. Being skinny, and I'm no longer skinny, I'm struggling with this, and I always will probably, but being skinny doesn't make you healthy necessarily. There are a lot of skinny people who are unhealthy, but being overweight definitely doesn't make you healthy. So we need to deal with that and help our patients become more healthy. We need to take care of our own health and help them take care of their health as well. Okay, so we have clogged arteries, plaque building up in the arteries. So one thing we do, people with coronary artery disease, and now we're doing a better job of preventing this. Like my physician is like, Scott, you're not getting any younger, you're getting older. My dad died of a heart attack, and in my ancestry, I have a genetic predisposition to have high cholesterol. Even if I have a good diet, I still have a high cholesterol. And so my physician is watching that. So when I go several times a year and get my blood drawn, we're looking at cholesterol levels. I'm on cholesterol medicine already in my 50s, blah, blah, blah. So we're trying to do, I think there's a movement in America to try to be a little more upstream and in preventing stuff from happening. And so we're identifying these risk factors earlier and giving people, prescribing medication to keep their cholesterol down or whatever. So I would encourage you, this is some good videos on angioplasty. So whenever you see this plaque building up in the arteries, we want to increase the blood flow. So we got to increase that space, enlarge that space so blood can flow through it. And so these videos really are great, and there's good reading in there too, as well. And I want you to read those. I want you to read that as well, not just watch the video. But the video really illustrates how the catheter comes in through the artery, through the artery, and inflates a balloon, which smashes the plaque, enlarging the opening for blood to flow. And it's really, really cool. And there's also, so you'll see that, and you'll see that it's also the way they place the stent. A stent is a mechanical way of opening, the balloon opens the artery, smushes the plaque, but the stent keeps it open, and blood flows through the stent. So the stent keeps that open. So you want to watch these two videos. You might want to pause it now and watch the video. And when you think about, there's also a way they remove the plaque. They'll do an endarterectomy, and they'll go in, they'll slice that open, they'll remove the plaque. They might put a shunt to blood flow while they're doing that. They'll put a shunt here, and they'll bypass that, get rid of that plaque, sew everything up, blood's flowing through again. So you want to know the angioplasty, which is the balloon enlargement, They might have an angioplasty with stent placement, and you might have patients with multiple stents placed in various arteries to promote blood flow. Okay, so the angioplasty is that balloon and enlarging the space. The stent is the mechanical means of keeping it open, and the endarterectomy is the removal. Anytime you see ectomy, that's a surgical removal of something. Laminectomy, surgical removal of vertebral lamina. I'm trying to think of another one. What's it called when you have your appendectomy, right? So if that's an ectomy, you're removing the appendix. So anyway, whatever, you get the idea. So those are things that are really cool, and you'll see a lot of patients that have had these and are recovering from these. Not a big recovery from those usually. What we see more of a profound recovery from is the coronary artery bypass graft. We call that cabbage, which is kind of cool because it's easy to remember. Coronary artery bypass grafting. So what they'll do is they'll take blocked arteries or arteries that are just kind of, the walls are worn down. They may be prone to rupture or something. A lot of times it's just blocked arteries that they can't open. And they will take a good section of arteries from somewhere, they'll harvest it, and they'll replace that clog. They'll remove the clogged part and replace it with that harvested artery. These are really good videos and websites with some really good information. If I remember right, I think one of these is an actual surgery, so be mindful. Some of you, I don't know, maybe you don't like that kind of stuff. Maybe you can't handle it. I think you all can handle it, so. But you're warned, so be careful of that. I threw some stuff in here that might make you nauseous or something, but those are great videos. So when we think about cabbage, when we see somebody after a cabbage, to do the cabbage, you have to crack the sternum and go in and operate on the heart. So when they sew all that up, you have these sutures, and they have afterwards, they have cardiac precautions, but they also have sternal precautions. So there's limitations on activities having to do with the heart. We don't want them to be immobilized, but we want them to rest for a few days. We want them, it's going to take them several weeks to be able to do things that they were doing before. The sternal precautions have to do with those sutures and that healing wound here, that healing incision, right? And so sternal precautions usually involve movement of the arms, movement of the, especially at the shoulder. So we don't want to be doing, depends on where you go and what the what source you look at, what the sternal precautions are. But usually we don't want people raising their arms past 90 degrees. And initially, the first few days, they're really keeping their arms in. They're given a pillow of some kind, of teddy bear or pillow to hug while they're moving, while they're getting up, while they're moving, so they don't use their arms. We don't want them pushing, we don't want them pulling. We don't want to, the go-to is we don't want them to be holding any weight or lifting any weight above 4.5 to 5 pounds. So like a gallon of milk is the example that people can relate to. They're told don't lift anything heavier than a gallon of milk, because a gallon of milk's pretty heavy. So, and if they do things two-handed, it helps. But so they're really restricted for, especially the first few weeks, and up to 8 to 10 weeks, they can't resume this. I did see on one article that talked about raising one hand over the head. They're not allowed to do that, but they can raise two over their head. And I had never seen that before. Always we're like, don't raise your arms above 90 degrees. Don't abduct at the shoulder, right? You don't want to be spreading this tissue out here because it pulls on those sutures. So anyway, we don't want to be reaching behind their back and all that. We want to keep their arms in. We want to protect those stitches. Okay, the incision. So sternal precautions are all about protecting that. Okay, so there's a lot of good reading in your book about that. It's about all I wanted to cover, really. But be looking up those sternal precautions so that you'll be very familiar with those. We talked about removing the plaque, the endarterectomy, removing the plaque. There's a couple of really cool videos on this. This is a animated video. This is an actual procedure, so that's really nifty. You want to watch that for sure. And notice that the plaque removed from the carotid artery, that plaque is a high, like I mentioned before, a high stroke risk. Remember that an embolism is a blood clot that on the move, right? A thrombus is a blood clot, and an embolism is a blood clot that is mobile. It moves, it gets clogged somewhere, which increases the risk for stroke, for sure. My thumb works better on this thing for some reason. Okay, myocardial infarction is a heart attack. It's caused by a blocked blood vessel, which causes cardiac muscle to be damaged or to even die. And these are some of the risk factors. And these are going to be recurring in all kinds of other conditions: coronary artery disease, diabetes, etc. High blood pressure makes you more, if you struggle with high blood pressure, you're more at risk for developing a heart attack. 47% of cardiac deaths occur outside the hospital, which makes sense to me. They just have a heart attack, they die, they can't get to the hospital for treatment. All right, so we treat that through CABG, angioplasty, beta blockers, medications. We want to be aware of their precautions, and when cardiac arrest is when the heart stops functioning. So we have a heart attack, which is cardiac muscle to be damaged or die, and then cardiac arrest. If somebody goes into cardiac arrest, that's when their heart is just not functioning. They go into cardiac arrest. Okay. All right. So be thinking about, this is the time during a normal class when everybody's here, when I'm talking to people, and I'm asking you questions, and we have a discussion about how these things that we've just talked about could impact performance. So I want you to be thinking about how, somebody with coronary artery disease, who's had a heart attack or whatever, that has heart issues, and decreased blood flow to various parts of the body, how that impacts people's functional performance. Usually these people that have these conditions we're talking about today, and most of the people we see that have been to the hospital, have had some kind of a surgical procedure, they're weak. They get tired easily. So we say they have decreased endurance. I was taught endurance in school, and then when I was practicing OT in first few years, I was told, don't use the word endurance when you're documenting. Medicare hates that word, blah, blah, blah. So I started using activity tolerance. And that's just part of my language now. I use activity tolerance a lot, and I like that. What is their ability to tolerate engaging in occupation, performing various activities? So that's a good way to think about it and talk about it. But endurance is good too. I think endurance is not a big deal anymore to talk like that. That's probably just me from like the 19th century, okay, 1900s. The 19th century would be the 1800s, so this would be the 1900s, the 20th century. Okay, but how does this impact their ability to stand and cook and to shower? Showering is one of the most taxing ADLs that our patients engage in, and it's surprisingly taxing and complex. There's a lot that goes into that. And how is dressing when you can't raise your arms and reach and lift, and very, very impacted? Okay, as ADLs are. So be thinking about that, and you have in your exploratory activity, in your thread of discussion, you talk about that. So that's all I'm going to say about that. Respiratory conditions that we see. These are very common respiratory conditions that we see. Chronic obstructive pulmonary disease is kind of a I don't know, I call it a catch-all, maybe that's not a good way to put it, for emphysema, and we're going to talk about some of these. Pneumonia. We see a lot of people with pneumonia, and right now there's been an increased incidence of COVID-19, the flu, and RSV, another respiratory condition. We're seeing that nationwide. There's a lot of people getting respiratory diseases, and some of these can result in pneumonia. Okay, so you'll read in your reading about how normal lungs function. They walk through that very, very well. Air comes in, goes through the air sacs, the alveoli, and there's an exchange there of oxygen going to the body in the blood, and the waste, the carbon dioxide, being taken out. So the air coming in brings in oxygen. The air going out, when you exhale, takes out the waste, or the carbon dioxide, and removes it. It's just an amazing process. Congestive heart failure, for some reason, is lumped in here. And I see a lot of patients with congestive heart failure. As they get older, their hearts just begin to wear out. They've got some arteries that are clogging, and their heart is just not putting out, with each pump, it's not putting out as much blood as it needs to. And the heart is having to work really hard to get the blood out there. And so we're going to see people that, and in your book, you'll see the etiology and all that stuff. You'll see this in your book. I don't need to go over that. So what we see is patients who are weak, who literally hardly ever have any energy, or they don't have very much energy. Which, when you don't have any energy and you're tired all the time, you don't feel like doing anything. So then they're very sedentary, which just feeds into the weakness and makes the weakness worse. So we want them to be active, but they can only do so much because their hearts are not putting out enough blood flow, and their cells need the oxygen, they need the nutrients to make energy, right? And so they just don't have the energy to do stuff. So think about how that impacts occupational performance. Some of our patients, we can strengthen them and we can help them improve their endurance, but for some of our patients, like our CHF patients, oftentimes we can only improve their strength and their endurance so much because of their condition. Now, how do they engage in these purposeful activities? Strengthening is one thing, but if we can only get so strong and our endurance to such a certain level, how can we adapt the activities, adapt the environment? How can we use compensatory strategies and adaptive equipment to make it easier on them to engage in these activities, to perform these activities safely and independently, which is what we're after. All right, and we're going to be teaching them on management, and their health. Emphysema is a respiratory condition. It has to do with the destruction of the walls of the lungs, the walls of the alveoli. And I tell people that when you have emphysema, every time you draw in a breath, your body's just not, your lungs aren't capturing as much of the oxygen as it needs to, right? As you used to be able to. So, for example, people will smoke for years and they build up. We have the alveoli aren't capturing the oxygen that it used to, and so that's why they're breathing more rapidly. So when you and I breathe and we have good, healthy lungs, we just breathe normally, and our lungs are capturing the oxygen that they need to capture. When you have emphysema, COPD, or whatever, your lungs aren't able to capture all that oxygen, and so you have to breathe more rapidly. And so what we see with people with these conditions, oftentimes, they're breathing more rapidly. They're breathing, and they may become very short of breath if they're doing anything that it has any exertion at all. So and maybe no one's really explained that to them. So I have a habit of explaining this to people. That's why you breathe so quickly. So if you have a normal patient, if you took your respiration would probably be around 14, 16 breaths per minute, right? normal is 14 to 20, but usually you and I are doing probably 14, 16, maybe 12, maybe. So we take in a nice deep breath. But when people with respiratory conditions like emphysema, COPD, a lot of times they're taking in 20, 22, 24 breaths per minute. The respiration rate is higher because they need to breathe more frequently to capture the oxygen that they need. And even then, it's probably not enough, which is really a great reason to, and that's the reason why we are so big on deep breathing, diaphragmatic breathing. If your lungs aren't getting the job done, these are my lungs. If your lungs aren't getting the job done, you have a diaphragm here, just a bladder for air. It's awesome. So take a second, put your hand right here, right below your sternum, right below your sternum right here. This is your bladder. You can feel that bladder right there. Right above, right superior to my flab is my bladder right there, my diaphragm. And I learned how to do this when I was learning to play a saxophone in fifth grade. I started learning how to, they said breathe into your stomach, but they're saying really what you're doing, breathe into your diaphragm. You can put a lot of air in there, but it's not normal to do that. So we have to kind of train ourselves to do it. And it doesn't take long to get good at it. So I'll have my patients put their hand right here, put their fingers right there on their bladder. Breathe deep and fill up that diaphragm. And we practice that. Diaphragmatic breathing. That's what we call that. And one cool thing to do, to teach them, diaphragmatic breathing, and we call it diaphragmatic pursed lip breathing. So we're going to go in through the nose and then out through the mouth, like we're with pursed lips. And I always say, like we're blowing out a candle. So I'll say, smell in a rose, breathing deep into that diaphragm, and then blow out a candle. I know it's cheesy, but it works. They remember that. Smell in a rose and blow out a candle and breathe into that diaphragm. It takes a little bit of practice, but they can get really good at it. So when they find themselves beginning kind of short of breath or having to breathe more rapidly, do that and get it and help them get into the habit of doing that. And it really works. Their body gets more oxygen with every breath. And if we can get them to get into the habit of doing that, it really is a huge help to our patients with these respiratory conditions. So, okay, you're getting short of breath. What are we going to do? In through the nose, out through the mouth like you're blowing out a candle. Smell in a rose, blow out a candle, and breathe into that diaphragm. Okay? All right. Smoking's bad for you. Okay? Stop. Quit now. And by the way, my patients who smoked forever, I smoked since I was 12 years old, whatever, and I'm, 86. Stop now, because you'll just make it worse if you keep smoking. And if you stop now, your lungs do have an ability to begin to repair to some degree, and it will help. They're not going to be like they were when they were, when you were 20. That's okay. But anything's better is better. So if it's better, it'll be good for you. So stop smoking. Whenever you stop smoking, it's a good time. Now's a good time to stop. Now we have vaping, of course. Vaping thrashes your lungs with various chemicals, and that's in the PowerPoint here in a little bit. So, all right. You see these things, results in a breakdown of the alveolar wall. You might see people with a pneumothorax, which is a collapsed lung. Hypoxia is too little oxygen. We don't want that. Too little oxygen in the brain, right? Barrel chest, anorexia, fatigue. Okay. And emphysema is treated with avoiding the irritants that cause it in the first place. Pursed lip breathing. Bronchodilators. I think I spelled that wrong. It's not dilators, it's dilators. So bronchodilators, chemicals like that, and this is what the inhalers are for. They're bronchodilators that enlarge or dilate the bronchi so that more air can get in there, more oxygen can get in there. And that's what inhalers are for. Okay? So you see, this is kind of a cute old guy here which illustrates what a normal lung looks like. This illustrates what an emphysematic lung looks like. And so from the outside, you might see this gentleman here. This is what he would normally look like. But if he has emphysema, he's going to have more of a barrel, call it barrel chested. You can see that. If you can't see that on the video, you can see that in your PowerPoint. Okay. So pneumonia, there's 3 types of pneumonia: viral pneumonia, caused by virus, bacterial, caused by bacteria, and aspiration pneumonia. Breathing in food or beverage particles into your lungs can cause pneumonia, and it is a significant cause of death for especially elderly folks. So, and we have these categories. Nosocomial hospital is, so sometimes they'll get pneumonia in the hospital. That's what that means. They may acquire pneumonia just in the community, or they may aspirate food or beverage. And people that have allergies, or the people who get, we'll see increased pneumonia during allergy season. I've actually had a pneumonia just from having allergies and all the stuff, the congestion and all that. So people with bad allergies, as they get older, are more at risk for developing pneumonia. I'm one of them, okay? So we'll see people with pneumonia, and my pneumonia patients are weak. They get short of breath easily, they're weak, their endurance is poor. So what we need is to, usually it's a variety of strengthening, increasing their activity tolerance, endurance, and finding, Dr. Estes will probably talk a lot about energy conservation, work simplification. How can we simplify this activity so you can how can we simplify dressing for you? How can we simplify showering for you? How can we do this, organize this in such a way where we can conserve energy, right? When you're doing your laundry, how can we place things and situate you, maybe even have you seated in some activities, or use certain equipment or whatever to make this more simple and to require less energy so it's less taxing for you. Energy conservation, work simplification. Those are things that we use all day, every day in our practice. And these are perfect people for that, because they need it. All right. Cystic fibrosis, an inherited genetic respiratory condition. And it's usually diagnosed with children, right, in early childhood, often prenatally or in those early neonatal stages. It can also impact the pancreas, digestive system, reproductive system, salivary glands, sweat glands. And there's a faulty protein which causes thick mucus secretions that lead to blockages, damage, or infections in those affected organs. So the lungs are a big part of it, but it can affect other parts of the body as well. So treatment includes bronchodilators, replacement therapy for enzymes, postural drainage, percussion, coughing techniques. And the life expectancy, unfortunately, is only 37 years. This is a very good link to watch. So pause the lecture and and go to that link right now. Very good. You may have asthma or know somebody who does have asthma. We see patients with asthma, and usually we won't see them. That won't be their primary diagnosis that we're seeing them for. That might be what we call a comorbidity, something that they also have in addition to whatever it is we're seeing them for. Maybe they've had asthma for a long time, and now they have COPD, or they have pneumonia, or whatever. So, but they'll have these periods of severe inability to breathe, bronchial obstruction, right? So they can develop COPD later. They might, if it's severe enough, they might have hypoxia, tachycardia. Tachycardia is an increased heart rate. By the way, when you're doing your reading and you see words that you don't know, look them up. Look them up. Anything you see that you're not familiar with, look it up. Take the time and look it up. You see tachycardia, look it up. It's a rapid heart rate. Bradycardia, brady means slow. So cardia, of course, is the heart rate. or disease condition of the heart. So bradycardia is slow heart rate. Severe respiratory distress. So people with asthma want to avoid allergens. They want to avoid swimming and walking. Anything that triggers their asthma. Controlled breathing techniques and bronchodilators. Here it's spelled correctly. And you know a lot about COVID-19, right? I thought we were done with COVID-19, but it keeps coming back. You know, it's kind of like what's that show? I'm trying to think of the Survivor. Is it Survivor? Where they're on the island? It won't go away. I think it's been on TV for like 20-something years. It won't go away. So COVID-19 is like that. And these are the symptoms. And you know, there's a great website to go to. But we've just come out of that. We're just still dealing with that. But COVID-19 is one of those that may affect somebody a little bit, may not even barely affect them. And then the next person, it just waylays them. You know, puts them in the hospital, they're on a vent, might even kill them. It's just, you never know if you get COVID-19 how it's going to affect any particular person. It's just weird. And I would say also, talking about pneumonia, this made me think of pneumonia. It's amazing how pneumonia will sneak up on people. All of a sudden they have pneumonia. You know, it started with a cough, but they don't feel it and until it's really bad. And then it's like they're in the hospital. So it sneaks up on you big time. So, all right, COVID-19, here to stay. And there's a cool article on vaping I wanted to share with you. I know, I don't know, maybe some people in my generation are vaping, but most of us are, if we're doing that, we're smoking, you know, the old-fashioned cigarettes. We prefer the cigars or cigarettes. Vaping's a big deal. And, you know, man, when it comes to drugs and when it comes to vaping, there's just stuff in there that's so harmful. Anyway, walk through this. It's good. It's a good thing about vaping, and it's just an epidemic today, especially with younger folks, with people your age and younger. So, okay. And as you practice, you're going to see more of this than I have seen. You know, we didn't do vaping. We haven't really seen a lot. I don't have a lot of patients who vape, but you're going to see that in your practice a lot more than I saw in mine. So you need to be really up on that. And as you educate people on how to be healthy, of course, well, as I told my older folks over the last 20-something years, stop smoking. I don't beat them up about it, though. I always say I don't beat people up about smoking. You already know smoking's bad for you. That's what I tell them. You already know smoking's bad for you and that you shouldn't smoke. It's bad for your health. I don't have to beat you up about it, which is my way of telling them, reminding them that smoking's bad for you. Stop, right? But I tell them I'm not going to beat them up over it and then tell them that's bad for them. They already know that. And I would encourage them to stop smoking. You're going to have that and vaping. It's bad for you. You already know that vaping's bad for you and you need to stop because it makes you unhealthy. And the stuff that they put in there, you don't even know what's in there. And what is it, fentanyl right now that's getting into all the drugs, and it's just killing people all over the place. People don't know what's in there. They're taking a drug, they don't know that it's laced with stuff. People, it's just the way it is today. So anyway, you can really speak into their life about health. So just be thinking about as we wrap up and as you go forward into your other activities, what occupations would not be impacted with your condition, what occupations would be impacted, what occupations could be performed with adaptation. It's amazing if you really break down the activity, and you learn how to do this in activity analysis. If you break down an activity and problem solve, you can help your patients do just about anything they want if you really try. So how can we adapt? How can we modify? How can we change the environment? What adaptive equipment might make things easier or whatever? What occupations could no longer be performed? Maybe they've got to say goodbye to something. Hopefully we can figure out how to do whatever the activity is. But These are some questions that I would normally have discussion on in class, but we can't. So be thinking about those things as we wrap up. And there's the references, not a whole lot of them. So, all right, that's your video lecture for this week. Enjoy your exploratory activity, enjoy your reading, and enjoy your thread of discussion. I look forward to seeing and reading and going through all your thread of discussions and responding to them. All right, have a great week. See you later.